The following podcast is part of a certified educational activity titled Building Clinical Confidence in the Diagnosis and Multidisciplinary Management of Rett Syndrome. Access the entire activity and complete the post-test at peerview.com/QBS860. Downloadable slides and practice aids are also available.
Hello, I'm David Lieberman. I'm a child neurologist at Boston Children's Hospital, and I'm the director of the Comprehensive Rett Syndrome Clinic. Thank you for joining this unique AI case-based educational activity on diagnosing and managing Rett syndrome. After the initial presentation, you will have the opportunity to apply your knowledge to two AI-based patients to recognize signs of Rett syndrome and next steps in managing their care. Our goals for today are to expedite your diagnosis of Rett syndrome through recognition of relevant signs and symptoms, improve your knowledge of the latest evidence surrounding novel therapies for Rett, prepare you to develop a team-based, individualized Rett treatment plan in alignment with current evidence and guidance. So we'll first talk about early recognition and diagnosis of Rett syndrome. So Rett syndrome is a rare, debilitating genetic neurodevelopmental disorder. It occurs primarily in girls and women with an incidence of 1 in 10,000 to 1 in 15,000 live female births. There are boys who develop Rett syndrome, but they are fewer in number in our clinics. It's the second most common cause of severe intellectual disability in females. Most people have loss of function mutations in the MECP2 gene, which is located on the X chromosome at XQ28. Mutations are generally spontaneous rather than heritable. There are hundreds of disease-causing mutations in the MECP2 gene, and amongst them, there's about 8 more common mutations that account for more than 65% of cases, and those 8 are divided into 4 that are more mild and 4 that are more severe. Rett syndrome presents after apparently normal neurologic and physical development for the first 6 to 18 months of life. Then there can be some plateauing in development. There is then subsequent regression, which can occur often between 18 and 30 months of life. It can occur very quickly over a matter of days or over months. The clinical manifestations that constitute the core diagnostic features of Rett syndrome are a loss of acquired spoken language, and that could even be just the loss of babbling if they don't have words yet, a loss of purposeful hand skills. It doesn't have to be a complete absence of fine motor skills, but just regression in those skills, impaired walking or the inability to walk, and the development of repetitive hand stereotypies, which are often these hand washing or hand wringing movements that Andreas Rett recognized in his patients and helped to come up with the diagnosis. Rett syndrome is a multi-system disorder. It affects different aspects of the child and adult life over time. Some common clinical manifestations include seizures, GI problems, including constipation, gastroesophageal reflux, and dysphagia, problems chewing and swallowing, abnormal muscle tone, usually hypotonia earlier in life, and later in life that might turn to hypertonia. Scoliosis or kyphosis can be seen. Sleep problems, either sleep initiation or sleep maintenance or both. Breathing irregularities, which could be breath holding episodes, hyperventilation, some heavy breathing, air swallowing or air puffing, and autonomic dysfunction, including vasomotor disturbances, where their hands or feet get cool or mottled in appearance, cardiac dysrhythmias, which are prolonged QT intervals, which could predispose them to torsades de Pons, and pseudobulbar symptoms, including inappropriate laughter and crying. The 4 stages of Rett were described first by Ben Hogborg. There is a early onset where the developmental delay becomes apparent, then a stage of regression where there's a loss of previously acquired skills, then a plateau, and actually the individual spends most of their life in this what we call the pseudostationary phase, where some things might get better and some aspects might get more severe. And then not all patients enter this late motor deterioration, but some do, where they develop some Parkinsonian features, including tremor, shuffling gait if they're ambulatory, decreased mobility, and worsened scoliosis. So to have a diagnosis of classic Rett syndrome, you needed those four main features I mentioned earlier: the regression in communication, fine motor skills, problems with gross motor function, and hand stereotypies. If you only have two out of the four main criteria, you would not have a diagnosis of classic Rett syndrome, but you may qualify for a diagnosis of atypical Rett syndrome. But in order to have that, you still need to have regression, but you need 5 out of these 11 supportive criteria. These are the breathing disturbances when awake, bruxism while awake or teeth grinding, impaired sleep, abnormal muscle tone, peripheral vasomotor disturbance, scoliosis, kyphosis, growth retardation, small hands or feet, the inappropriate laughing and screaming spells, a diminished response to pain, and intense eye communication or eye pointing. So how do we incorporate genetic testing into the diagnosis? Well, right now, Rett syndrome is a clinical diagnosis based on the regression and accompanying features. And the appearance of an MECP2 mutation is supportive of the diagnosis, but is neither necessary nor sufficient for a diagnosis of Rett syndrome. But learning a little bit about the variants can have some information regarding prognosis. But two girls with the same exact mutation at the same age may have different levels of severity, in part because of differences in the pattern of X activation. Since girls have 2 X chromosomes, only one is active in any cell. And although it could be random and be 50-50 between the wild type allele and the mutant allele, it may also be skewed towards either a more severe or less severe phenotype by how much wild type copy you have present. 95% patients that present with classic Rett syndrome have a mutation in the MECP2 gene, but somewhere between 40% and 75% of atypical Rett syndrome patients have a mutation in the MECP2 gene. What are some of the other things we have to consider when evaluating somebody for Rett syndrome? Well, autism spectrum disorder is something that's considered, particularly when the patient's undergoing the regression. They might lose eye contact and have some social withdrawal. One of the main differences between autism and Rett syndrome is that the eye contact returns much quicker in those who have Rett syndrome and do not have autism compared to patients who do have autism. But we certainly have patients with Rett syndrome that do actually have a formal autism spectrum disorder diagnosis as well. Angelman syndrome can be distinguished by presentation and some of the EEG findings for Angelman patients. The cerebral palsy is something that many of our patients present with, but we now know is due to Rett syndrome and not idiopathic cerebral palsy. Neuronal ceroid lipofuscinosis, which is a lysosomal storage disorder that's a degenerative process. I should add here as well that while Rett syndrome is progressive, it is not neurodegenerative. There's no ongoing cell death or anything in Rett syndrome. So then the last is nonspecific developmental delay, which could be considered. So how does the diagnosis of Rett syndrome appear in most patients? Well, there was a study done in 2015 that said the mean age of diagnosis at that time was about 2.7 years. There was a diagnostic delay between 1 or 2 years between symptom onset. Some of the things that led to the diagnosis was the presence of developmental delay and regression, the loss of acquired hand skills, and the appearance of hand stereotypies, and a deceleration in the rate of growth, becoming microcephalic. So Rett patients are often diagnosed by neurologists, by developmental pediatricians, or by geneticists. The benefits of an early diagnosis are trying to establish the disease, the prognosis, and counseling on the comorbidities, initiating therapies, particularly physical therapy, occupational therapy, and speech therapy, looking at other comorbid features and trying to treat them aggressively, and then also the initiation of targeted treatments, which might be more effective when used early. We're still learning about that part. So moving on to foundations of Rett syndrome care, and we'll talk about novel and emerging treatments. I'll first talk about trofinetide, which is the first FDA-approved treatment for Rett. It was approved in March 2023 for adults and for children 2 years and older. Dosage is weight-based. It's an oral solution administered by mouth or by G-tube twice daily. It is a synthetic analog of the IGF-1 tripeptide glycine proline glutamate, but it has some modifications that make it more bioavailable and longer lasting in the bloodstream. So the IGF-1 tripeptide is believed to improve neuronal function and glial function, as noted in the MECP2 knockout mice that was done initially in male mice. And we saw an improvement in synapse density, lifespan, motor function, and other behavioral aspects in the mouse model. In the FDA approval of trofinetide, there was this phase 3 trial called the Lavender trial that involved 200 girls and women with Rett syndrome age 5 to 20. They had to have classic Rett syndrome as well as a pathogenic mutation in the MECP2 gene. They had to be 6 months out post-regression, and they were randomized in a double-blind, placebo-controlled fashion, and treatment was for 12 weeks. Then there was an extended open-label extension portion called LILAC for those who were eligible and wanted to continue. The co-primary efficacy endpoints were a parent-derived measure called the Rett Syndrome Behavior Questionnaire and a clinician-derived measure called the Clinical Global Impression of Improvement. So in the RSBQ score, there was a decreasing scores show improved behaviors, and both the trofinetide group and placebo group showed improvements at 2 weeks, likely due to placebo effect. But then over time, the difference in the trofinetide group and the placebo group diverged, and you could see there's a statistically significant improvement in the RSBQ score of about 5 points compared to those who were receiving placebo. The Clinical Global Impression of Improvement score diverged after 6 weeks or so and became statistically significant at 12 weeks. It's a small improvement, but statistically significant. Some of the side effects that were noted in the Lavender trial were a high incidence of diarrhea. Most Rett patients have constipation at baseline. Very few have diarrhea. Some of the diarrhea is probably due to the vehicle that the drug is dissolved into, because there's a 19% rate of diarrhea in the placebo group, which is much, much higher than in our typical Rett patient. The reason that these patients had as much diarrhea as they did probably is they were put directly on their goal dose based on weight, not titrated up. And if they were on osmotic or stimulant laxatives, those were not removed ahead of time because you wouldn't know whether the patient was going to get trofinetide or placebo. There was also a high incidence of vomiting in the trofinetide group compared to the placebo group. But the diarrhea, is mostly self-limited. It seems to improve over time. In fact, many of our patients who are on trofinetide and are off their medications for constipation actually have to go back onto them at some point because the constipation might return. But 75% of patients receiving trofinetide did complete the study. So in the LILAC portion, the open label extension, patients continued to take the trofinetide for 40 weeks. And what's shown in these figures is in the black are those who were on placebo in the lavender trial, and the blue are those who were on trofinetide in the lavender trial. And both groups show continued improvement over time over the 40 weeks on the RSBQ score, as well as the CGI score. On the left panel on the CGI is just showing you the 12 weeks of the lavender and then the continuation onto lilac. So in the improvements seen, both the caregiver assessed RSBQ and the clinician assessed CGI scores, and the side effects in the lilac trial were also the diarrhea, vomiting, and in this case, COVID, because of the time that the trials were conducted. In addition to the lavender and lilac trials, there was an open label trial called Daffodil that was restricted to girls 2 to 5 years of age to see how dosing for them was compared to those girls and women 5 years to 20 years. So they got 2 grams BID, and then at week 2 went up to 4 grams BID, and then depending on their weight went up to 5 or 6 grams BID. It was at least 21 months of treatment, and the co-primary efficacy endpoints for this were safety and tolerability and pharmacokinetics, and there were some exploratory efficacy, both clinician and caregiver. And here's what the clinician saw. This CGI score shows improvement over time, over the in this case up to 78 weeks of drug on given open label, and the caregivers also rated improvements over time. The diarrhea and vomiting were similar in this treatment trial, even though in this case they were titrated up. Blarcamesine is another investigational agent for Rett. It is a sigma-1 receptor agonist. It's a muscarinic receptor modulator. In the MECP2 knockout mouse, this blarcamesine compound restored cellular homeostasis and synaptic plasticity and increased the release of BDNF, resulting in improvements in motor, sensory, and autonomic symptoms. In a phase 3 trial in women that was conducted, those were 18 to 45 years of age. There was 72% of patients in the treatment arm showed a significant improvement in the RSBQ score versus only 38% in the placebo arm. When the trial was performed in children aged 5 to 17 years of age, there was significant improvements in the RSBQ score, but it was more of a trend, at least at the 12-week mark. Most of the lack of significance was due to the high placebo rate, high placebo effect in this trial. So there's still ongoing discussion about what the next steps for this compound will be. Other avenues for investigation include TSHA 102, which is an AAV9 mediated delivery of a mini MECP2 gene. Is provided by intrathecal injection, and it's currently in a phase 2 trial, soon to be starting a phase 3 trial. There is another compound that's also an AAV9 MECP2 gene delivery, NGN401. This is a full-length MECP2 gene. It's introduced by intracerebroventricular administration. It too is in phase 1-2 trials and moving soon into a phase 3 trial. So now I'll turn our attention to partnering across disciplines to manage Rett across the lifespan. In the 2020 consensus guidelines that have been published, the overall multi-system issues in Rett require primary care providers and other health professionals to manage complex medical comorbidities within the context of the whole individual and family. Some of the things that emerge at different time points are presentations that come up in different ages, and this consensus guideline in 2020 came out before the 2023 approval of the trofinetide compound for Rett, but it focuses on symptomatic and overall care of patients with Rett syndrome. So we think of Rett syndrome through the lens of a multidimensional team-based approach where the patient is at the center of care, with the primary care provider orchestrating many of the consults to other team members, include pulmonary, GI, behavioral specialists, PT, OT, and speech therapists, geneticists, and neurologists. And individuals with Rett syndrome should have regular wellness checks and have family counseling and having support on all of these areas, as I just mentioned. And a consideration upon hospitalization is anesthesia sensitivity may be increased if they are need to be sedated. Often lower doses of anesthetic may be needed, or they might experience delayed awakening from the anesthetic. We try to get a EKG before they're undergoing anesthesia to make sure they do not have QT prolongation, which would affect what medications they used for sedation. And the staff should note if there's impaired proprioception, lack of hand use, immobility, cold extremities, disordered breathing, and high fall risk, so they know what their baseline is. Daily range of motion is important for hospitalized patients to prevent contractures. Altered pain response does not require changes to analgesic approach. The key takeaways from today's talk are that Rett syndrome is a rare, severe neurodevelopmental disorder that primarily affects girls and women, with rare cases in boys. It presents with a wide range of symptoms. Management guidelines recommend a multidisciplinary approach tailored to the evolving needs of patients and families from childhood through adulthood. Historically, care has been focused on symptom management, targeting seizures, mobility, feeding, communication, and behavioral challenges. And in 2023, trofinetide became the first FDA-approved therapy, marking a shift towards targeted symptomatic treatment based on Rett's underlying biology. Additional treatments are in the development pipeline. That brings our discussion to a close for today. I hope you found the activity informative and useful to your practice, and we encourage you to access additional program materials, including downloadable slides and practice aids. Thank you very much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from ACADIA Pharmaceuticals Inc. To access all materials for this activity, visit peerview.com/QBS860.